Hello, everyone. My topic is hexagonal pacing CRT, still a useful pacing modality for the heart failure to correct LBBB. In fact, I want to change the title into the hexagonal pacing is very important for the correcting LBBB because I'm a fan of continuous system pacing, especially hexagonal pacing. Let me start from the date on the comparison of the CSP and biventricular pacing. From the meta-analysis, it published about 1 month before its latest study about the comparison. Let me see the details. The meta-analysis enrolled about 30 studies, and about half is a comparison of hexagonal pacing and biventricular pacing, and the other is about the LB pacing and biventricular pacing. And this study is from our center. Let me see the result. From the result, we can find that the hexagonal pacing is very superior than the biventricular pacing, especially in the LV ejection fraction, the LV side, the function class, and the echo response. But as to the all-cause mortality has no difference between the hexagonal pacing and biventricular pacing. So let me back to the definition of the hexagonal pacing CRT. What's the hexagonal pacing CRT? In fact, if the LBB can be corrected by hexagonal pacing, we need the LV rate? I don't think so, because maybe we need it works only as a backup. It's a bystander. But the LBB can be corrected by hexagonal pacing, but still with the interventricular cardiac conduction disease. Maybe the LV pacing work as a supporting character. So depends on the hexagonal pacing can correct LBB or not. I think most times the hexagonal pacing is a main character. We needed the fusion pacing. Absolutely, and traditional CRT, the biventricular pacing is still the golden standard in the pacing modality for the heart failure with LBBB from about 20 years before from the new indication in the ESA this year. But from this study, we can think about another question. This study is published about 2 years before. He compares LBB pacing and biventricular pacing. But finally, he got the results that the LBB pacing was not inferior to biventricular CRT. So until now, we still have no definite result or conclusion about the LBB pacing is superior to biventricular pacing. So why? Maybe we should go back to the pacing modality. If the patient accepts the LBB pacing, absolutely the resynchronization in left ventricular is totally, but we still has no the resynchronizing about the intraventricular and right ventriculum. So maybe it's not the perfect resynchronization pacing modality for the LBB pacing. Now back to the hexagonal pacing. It's useful, it's available for all the patients. I don't think so. Maybe from this figure we can find that only about 60 or 80% patient can the LBB can be corrected by the his bundle pacing, because about 40% of the LBBB block site is below the his bundle. So not all the patient can get the benefit from the his bundle pacing. As to the his bundle pacing, we had many data, many study to demonstrate the benefit. It's an interesting study published this year. The title is about ventricular repolarization is improved by his resynchronization therapy, but not by ventricular pacing. So let me say the details about this study. From the figure, we can find that this is a normal QRS. This is the his bundle pacing. It's very similar to the normal QRS repolarization. But as to the biventricular pacing, we found that it's quite different with the normal QRS. It's quite different with the normal repolarization. So I think that's the difference between the biventricular pacing and the his bundle pacing. So except the block site of the LBB, it still have many challenges about his bundle pacing. And let me say the details from the two cases. The first case is that the patient is an old woman, and he accepted the double chamber pacemaker about 10 years before for the atrial ventricular block. This is ECG of the right ventricular pacing, but unfortunately, about 5 years after implantation of the RV pacemaker, the patient got the heart failure. The LV ejection fraction decreased from 50% to 27%, and this patient accepted the his bundle pacing upgrade. Why choose the his bundle pacing upgrade, not the LBB pacing upgrade? I think this patient this is the RV pacing ECG. We can find the QRS duration is not very longer, and the SX is not very different with the intrinsic conduction. So the patient is very easy to got pacemaker-induced heart failure. I want the patient got the totally resynchronization, except including the intra and the interventricular resynchronization. So we choose conduction system pacing, especially his bundle pacing. Now we can find that this is an A wave and his bundle potential. We can find that the A wave is associated with his bundle potential, but the his bundle potential is not associated with the QRS wave. So from this, it indicated that the patient, the block site is below his bundle or in the distal end of the his bundle. So now how to reach the his bundle pacing? We should push the lead a little far, a little more away, far away from the atrial side to the ventricular side. So when the his bundle potential disappeared, we can do the pacing mapping. And the pacing QRS morphology is nearly as same as the intrinsic QRS morphology. So I think this is his bundle pacing. And finally, we can find that if the patient after accept the his-bound pacing, the class duration is only 100. It's very shorter than the RV pacing. The RV pacing class duration is more 70. So about half a year's follow-up, the exact fraction increased from the 27 to 42%. And now the exact fraction is more than 50%, and the patient accepts another pacemaker replacement. So this patient, his life quality is very high. And sometimes we couldn't reach the LBBP, and sometimes we also couldn't reach the his-bound pacing. So how to reach the conduct system pacing? Another pacing modality is about atrioventricular node pacing. And this case has accepted by the journal of the Jack case report is from our center. This patient is 74 years old. He's very unlucky. At first, he accepted the aorta and mitral valve replacement about 50 years before due to the valvular heart disease. And about 5 years after that, he accepted the atrial fibrillation ablation and got the third-degree atrioventricular block. So the patient accepted the single-chamber pacemaker implantation. And about 2 years before he came to our center for the heart failure and the ventricular tachycardia, the LV ejection fraction is only 26%. And this patient accepted the CSP implantation and upgrade. At first, we wanted the LBB pacing because we consider about the lifetime of the pacemaker. But unfortunately, although the pacing modality, the mapping pacing modality in LBBB1 is very okay, but during the school, and we found that we couldn't reach to the left side totally. And the curse morphology in LBBB1 is still just like this, and the R plum wave couldn't be found. So maybe I think the reason maybe is scar around the valve because the patient accept the valve replacement therapy about 20 years before. So we stopped here and we changed to another pacing modality or his-bound pacing. And we can mapping his-bound easily, but we found that the pacing threshold is very high. It's about 4.0 at 0.4 millisecond. So we give up the his-bound pacing. So now what we will do, the biventricular pacing for this patient, I don't think it's a good choice. So we try another pacing modality about atrioventricular node pacing. And we take back the light and the shades to the atrial side and do the mapping, do the pacing mapping. And we found that when do the pacing at a different rate, we can find the stimulation to the QRS duration is a little different, maybe indicates the atrioventricular node. So we do the late parameter tests, we found that the threshold is very okay, and we do the high rate pacing, we can find that the QRS duration is not longer than 300. That means that the pacemaker, after the pacemaker implantation, we can get the conduct system pacing totally. So finally, this is the ECG. We can see the signal of the stimulation, and this is the QRS, and it has no any signal between the stimulator and the QRS. And we can see the details of the airway ejection fraction. And about 6 months after the AV node pacing, the airway ejection fraction increased from 26 to 45. And now the patient had finished the 2-year follow-up, and the ejection fraction is around the 46. So in summary, I think the hip pacing is very, very important for the LBB correcting, but the hip pacing is not useful for all the patients, depend on the block site of the LBB. So for the patients who has the requirement of the high quality resynchronization, for example, just the case demonstrate, if the patient is the pacing-induced heart failure, or the LBB-induced heart failure with very low ejection fraction, maybe the hip pacing is very important. At least it's still useful for such patient. That's all. Thank you.